Good evening, everyone. I'm Michelle Borg. I'm the chair of the AMA Council of Doctors in Training Prevocational Special Interest Group. Thank you for joining us tonight, and I'm delighted to be facilitating our webinar on how we can help prevocational doctors better understand the new framework for prevocational medical training. Firstly, in the spirit of reconciliation, the AMA acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respects to their elders, to past and present, and extend that respect to all Aboriginal and Torres Strait Islander people present today. This webinar follows the release of last year's AMC's new national framework for prevocational PGY1 and PGY2 medical training, and it's for 2024 onwards. We have a wonderful panel of speakers tonight who will discuss the implementations of the framework in practice. I'll first introduce our panelists. So the first one is Associate Professor Andrew Singer, AM FACEM FIFM. Andrew Singer is Principal Medical Advisor in the Australian Government Department of Health and Aged Care, advising on policy for acute care, health classification systems, safety and quality in healthcare, the Medicare benefit schedule, private health insurance, as well as medical education, practitioner regulation, and workforce. He is Associate Professor in the Australian National University Medical School and Senior Specialist in Emergency Medicine at Canberra Health Services. Andrew is a former president of the Australasian College for Emergency Medicine, receiving the ASIM medal in 2011. He has also been with the International Federation for Emergency Medicine as a board member and committee chair, receiving the FIFM in 2010. He's chair of the Prevocational Standards Accreditation Committee and technical advisor to the Specialist Education Accreditation Committee of the Australian Medical Council and a member of its board. He was a member of the Order of Australia in 2018. Next, we have Dr. Dana Duncan, who goes by she, her pronouns, and is an ACRM trainee currently working in medical education and as a renal registrar in the Royal Darwin Hospital. Dr. Duncan has experience in prevocational training and accreditation as both a recent trainee and accreditation surveyor, and is familiar with the new framework and its implementation from an education and advocacy perspective. She has worked in recent years with both the AMC as a surveyor and also in her local prevocational authority, which is the Northern Territory PMAS, in guideline development in line with the new prevocational framework. Currently as Medical Education Registrar, Dr. Duncan is working with the RDH Medical Education Unit on redeveloping the Health Service Education Program in line with the new graduate outcomes. Alongside these roles, she is the immediate past president of the Australasian Prevocational Medical Officers Committee and a board member of the Confederation of Prevocational Medical Education Councils. Dr. Aidan Tan is a paediatric doctor and a medical leader. He has a diverse set of expertise across the health, regulatory, research and education sectors in Australia, in New Zealand and also internationally. And I'm also here, but I'll be the chair tonight. I'm a PGY3 Principal House Officer or an unaccredited registrar if you're from interstate in obstetrics and gynae. I'm currently working in Queensland, but I've also worked in New South Wales. I've been involved with the Australian Medical Association Prevocational Special Interest Group since I was a medical student, and I'm currently chair of the committee. My goal is hopefully enhancing prevocational training and improving consistency between the different hospitals and health services. We have a Q&A chat enabled tonight, and we encourage you all to post comments and questions online, and the goal is for us to try and answer all of those questions either tonight or post the webinar. Additionally, this webinar is being recorded and will be available on our website post-webinar. We also are planning to caption the webinar to enhance accessibility. Before we get stuck into the questions, we'll first hand over to Associate Professor Singer to provide a summary on his work with the framework.
Look, thank you, Michelle, and the AMA for the invitation. I acknowledge that I'm on Ngunnawal Ngambri country in Canberra, and I also pay my respects to elders past, present and emerging, and also my respects to any First Nations people that are on the webinar tonight. So I'm now going to share my screen, which worked before. We'll see whether it works again. Okay, now hopefully it looks like everyone can see the screen. So I've got, whilst it says slide 1 of 40, don't worry, I'm not going to do all 40 slides, but I'm going to move reasonably quickly through this. So if there's anything that you want more detail on, please feel free to post that in the chat, and I'm happy to sort of go back and explain things in a bit more detail as we go through the webinar. So essentially what we've got now is a revised 2-year prevocational framework. This has taken about 10 years to develop, following an initial inquiry that was done by the Australian Health Ministers Advisory Council, and I was part of that group at that time. And it's taken us a few years now, but we've finally got here. So a couple of things in particular to point out here. One is that general registration, the transition from internship remains at the completion of PGY1. You can see there why we've sort of added PGY2, and essentially to try and provide better support and structure. And also to note that if you participate within the framework, then you are exempt from the medical board's new CPD requirements. I think it's probably more accurate to say, rather than being exempt, participating in the framework allows you to satisfy that requirement without doing anything extra. And the framework does not prevent people from being able to enter specialist training in PGY2, where a specialist college allows that. And I might make a particular comment in relation to physicians training further down the line. So the key names, the key aims are there for you to see. I'm not going to bore you by reading them all out, but I guess it's very much what people have been doing as part of their internship and PGY2 for many years, even including when I was an intern, which I can assure you was a very long time ago now. But as I said, I think the framework sort of helps to add a bit more structure, hopefully to also bring better accountability into supervision. And in particular, the one area that we are taking advantage of here is to try and strengthen Aboriginal and or Torres Strait Islander health and promote cultural safety. And also just to point out again that it's meant to be a generalist year. So a quick overview, essentially there are sort of 3 themes here: training and assessment, the training environment, and quality assurance. And I'll go into detail about that now. So I'm going to start off with the training environment. So essentially there are national standards now for all training programs and terms, and those national standards are consistent across the country now. It used to be the case that individual states and territories had their own standards based on some generic AMC standards, but it's now a single set of standards that are used by the postgraduate medical councils, who have the role of accrediting training programs within the framework, and also the standards are there to guide providers in what prevocational training they provide. So there are essentially 5 standards that are used in accrediting training providers. So the organisational purpose, the structure and content of the training program, the delivery of the program, the support for prevocational doctors within the program, and then monitoring, evaluation and continuous improvement. And the major changes are sort of listed down, or I guess in particular, the ability to do better and targeted assessments through entrustable professional activities, strengthened Aboriginal and Torres Strait Islander standards, strengthened wellbeing, mandated term supervision training, and in the future, the ability to mandate community terms. So there are some slight differences between PGY1 and PGY2 in terms of what is the structure. So you can see that they're both a minimum of 47 weeks work. I'll talk a little bit later about where that can be a little bit more flexible where needed. For PGY1, it's a minimum of 4 terms. For PGY2, it's a minimum of 3 with a minimum duration of 10 weeks for each term. In terms of how you deal with specialties, so in PGY1, the idea is a maximum of 50% in any single specialty, and no more than 25% in any subspecialty within a specialty. For PGY2, it essentially is a maximum of 25% in any particular subspecialty. And what that allows us to do is that for a more general experience within a specialty, so general medicine or general surgery, etc., they're not counted specifically as subspecialties as part of that. It's you're expected to be embedded in a clinical team at least 50% of the year, and in reality, certainly for PGY1, we expect that to be much more than that. In terms of the maximum allowable time for a relief or term or night or specific night shift terms, 20% for PGY1 and 25% for PGY2. And then essentially there are a series of clinical experiences that have essentially replaced what used to be mandatory medicine, mandatory surgery, mandatory emergency medicine in terms of what each term has to provide. So essentially for PGY1, there are 4 clinical experiences. The first one is undifferentiated illness, such as working in an emergency department or working in general practice. The second one is chronic illness, which could be fulfilled, for example, through a term in medicine, or again, potentially general practice could also qualify for that. Acute and critical illness, which applies to terms such as emergency and ICU and some rural generalist terms. And then perioperative and procedural work, which essentially is the replacement for the mandatory surgical term. In PGY2, the mandatory requirements drop the perioperative procedural requirement. That's not to say that someone could do a term focused on surgical posts, but it's not mandatory as it is in PGY1. And you can see there essentially as part of the accreditation process, each term has to have a term description that describes all of those elements listed there. So here's some examples of what a PGY1 program looks like with the letters applying to each of the clinical experiences along the top there. So as you can see there, I'll just talk about the first example where you could do your first term in geriatric medicine, which covers both chronic illness and acute and critical illness. You could then do a rural general practice term that covers undifferentiated illness and chronic illness. You could then do a term in renal medicine where you're covering chronic illness and acute and critical illness. And then you could do a term in an acute surgical unit where you cover acute and critical illness and perioperative and procedural. I guess an important thing to note in that balloon there is that one thing that we've found when we've talked to different jurisdictions about how terms are described is that the names aren't consistent across sites or states, which has made it a bit of a challenge in terms of making sure that everyone understands what they're doing. This shows some examples as to what a PGY2 program might look like. So essentially the top one there is a 3-term year with acute psychiatry, so covering B and C, an emergency department in a metro setting that covers A and C, and then an integrated general practice and rural emergency term that covers A and B. And so there's plenty of options around that. That means that most people, even people who are entering specialist training in PGY2, should still be able to meet all of the domain, the clinical experience categories that they need to as part of that experience. All right, next we'll move on to training and assessment. So with training and assessment, essentially there are a couple of different aspects of this. One is there are revised outcome statements. So something that you may or may not have been aware of is that the AMC produces outcome statements for the end of medical school, which essentially medical schools all have to be able to demonstrate part of their curriculum. We also have similar outcome statements that apply to the end of participating in the framework. They have been revised in an attempt to try and better meet community needs in particular Aboriginal and Torres Strait Islander outcomes. The assessment part includes the inclusion of entrustable professional activities, which I'll go into detail on the next slide, which focus on clinical work. Both terms and EPAs are mapped to those outcome statements. And then at the end of the year, each health facility has an assessment review panel whose job it is to look at the overall picture about how you have gone, and then essentially provides a holistic assessment as to whether, if you're in PGY1, you have qualified to be recommended to the medical board for a general registration, or whether you have qualified to receive the certificate of completion of PGY2. So what's an entrustable professional activity? So essentially, it's a description of work that's undertaken in day-to-day clinical practice. The EPA itself is not the assessment, but it's a description of something that can be assessed. And in the assessment, essentially, the supervisor makes a judgment about how safely the doctor can perform this piece of work. So a level of entrustability, which generally goes from the lowest level, which is that everything has to be supervised all the time, to independent practice. We're not necessarily expecting independent practice for everyone at the end of PGY1 or 2, certainly for some things, but it essentially shows the range. Probably the best sort of colloquial way to describe it is, can I trust this person to look after my grandmother if they came in? So the 4 EPAs essentially cover these 4 tasks. One is clinical assessment, so pretty much what you would expect about history examination, differential diagnosis and management plan. The second one is recognition and care of the acutely unwell patient. So clearly that applies to someone unwell presenting an emergency department, but it also could apply, say, to a code blue or a MEC call happening on the ward that you happen to be working on. Prescribing, which essentially not only is about writing a prescription, but also about your ordering of drugs and fluids and blood products, etc., making sure that you're tailoring that to the patient's needs. And then finally, team communication, which deals with documentation handover and referral. So you don't have to, you don't, because as you know, some of these EPAs may not necessarily apply in every term. I'll go into the to what the requirements are about what needs to be done and when. So essentially the format is that your supervisor observes the activity, there's a discussion, and the idea is as part of your routine clinical work. So for example, your registrar might say to you, look, can you go and have a look at this patient, and I'm going to watch you, and then we'll have an EPA discussion after that. So the other important point is to note that it's not pass-fail. Essentially, it's a judgment of entrustability, and then essentially helps to provide an overall picture. So in terms of the number of assessments, the global requirements are a minimum of 10 across a whole year. And this is both for PGY1 and 2. And the aim is a minimum of 2 or 3 within each term. And then in terms of the specific requirements, EPA 1, so the clinical assessment, that's required at least 4 times across the year, and the other 4 EPAs, a minimum of 2 across the year. So you'll note that covers essentially 10. Adds up very nicely. At least one of your EPAs within a term has to be assessed by a specialist or the equivalent if they're your term supervisor. The others can be assessed by other health professionals once they've done the training in an EPA assessment. So as you can see there, other specialists, registrars, nurses, nurse practitioners, pharmacists, example, could be involved in the prescribing one, and others as appropriate. So here's sort of a brief example of an assessment within the term. So the idea is that you have a discussion at the beginning of the term about what your objectives are, what the term supervisor expects of you. You then might do EPA 3 at first. You then will have a midterm assessment, and then you'll cover EPA 1 and EPA 2 later on, and then you have an end of term assessment where essentially there's a discussion about whether you've met the goals of the term or not. Here's some examples of how it might work across the year. I won't go into that in detail, apart from noting a couple of things. So one is that the e-portfolio, which actually has been now implemented as of the beginning of last week, will be your record of training, and what you'll do is you'll be given access to an app that allows you to note down who the supervisor is, etc., and allows the supervisor to put in their ratings. Also, there's essentially looking at the outcomes, looking at the opinions from the EPA. That all then goes to the assessment review panel, who will then make a recommendation regarding a completion of the year. So as I said, the e-portfolio has literally just been rolled out, and essentially the aim is that it sort of allows you to track the achievement. We do note in particular that there are some outcomes, such as those relating to Aboriginal and Torres Strait Islander health, that may be difficult to cover within an EPA and an end-of-term assessment, because it will very much depend on your exposure to those patients. And if it's the case that you're not getting exposure to those patients, then there are other ways that you can complete those requirements through education. And you're able to record things that you've done in the e-portfolio. So in terms of certifying completion, as I said, there's no specific requirement to pass a specified number of assessments or terms. Satisfactory performance is essentially attainment of that required standard, which is in those outcomes. And then, as I've already said, in terms of certifying the completion, either a recommendation goes to the medical board that says that you are eligible to progress to general registration, or in the case of PGY 2, the health service submits evidence to the AMC that you have met all the requirements for the certificate of completion. So it's got TBC here, but I can confirm now that the AMC will be the authority that issues the certificate of completion based on the advice that it receives from the assessment review panel of the health service that you are employed in. And in terms of the evidence that's going to be required, it's clearly evidence that you've met the program length, that you've met the term requirements, and that you've achieved all the outcomes. And again, this just sort of shows, it's probably a bit small to see, but it shows you essentially how the evidence works. So I guess an important point to make here is that the 47 weeks is sort of based on the usual requirement of up to 5 weeks of annual leave, which most jurisdictions have. But if for some reason, for example, you have to take a period of sick leave, that means that you haven't fulfilled all the 47 weeks, then the assessment review panel has the liberty to be flexible and say, yes, you have achieved the requirements in any case, and you can still be recommended having completed that year. All right. I think I've probably already said most of what's there, but I guess particularly noting point 2 there around that it's not just a record of assessments, but the portfolio also can record what you've achieved in other training, and also if you want to use it as a procedure log, you you can use that as well as the ability to do goals and reflections. Okay, I won't talk that much about quality assurance because that's essentially the AMC's role in accrediting the postgraduate medical councils. So I will stop sharing my screen at that point, and I'm happy to start answering any questions. So Michelle, I'll hand back to you.
Thank you very much for that presentation, Associate Professor Singer. We do have some questions that have come in, so we're seeing some coming in through the Q&A. We've also, as part of the registration, asked for people to send questions. So we'll start with a couple of ones that have come in via the emails and mixing them with some of the ones in the Q&A, and then we'll focus on the Q&A questions. So the first one I'll ask, it will be directed towards you, Associate Professor Singer. There is a question regarding the requirement for the certificate completion. So would all the colleges require the completion of the certificate, and also on a similar note, what are the consequences if someone does not do the certificate of completion?
Okay, so a couple of things to note here. One is that the certificate of completion does not apply to international medical graduates. And so whilst colleges have been asked to consider whether they would accept this, whether they would make the certificate of completion mandatory for Australian graduates, they won't necessarily be able to do that for IMGs. So far, some colleges have already signalled that they will make this a compulsory requirement, but not all. So, for example, the College of Physicians have essentially in particular, have had a discussion with the AMC and the Postgraduate Medical Council of Victoria, because in Victoria, in particular, there are a number of physician trainees who start in PGY2, and there's a statement that if you go to the PMCV website, you can find. But essentially, the gist of it is that it should be possible for a physician trainee in PGY2 to fulfil both the requirements of physicians training for that year, as well as fulfil the requirements of the certificate of completion. But the college will not mandate that they have to that they have to get a certificate of completion if they are in physician training. I guess the tricky side to that is, of course, that if you say you get to PGY 3 or 4 and then decide that you don't want to do physician training after all, and you want to go and join a college that does require the certificate of completion, then you're probably going to need to have a detailed discussion with that college around it. So certainly my advice to everyone is that you should aim to complete the certificate of completion, because you never know when you'll need it.
Thank you very much for that answer. The next question I'm going to direct toward Dr. Duncan. So it's a bit of a mixed question. We have had a few questions related to leave. So sick leave, professional development leave, maternity leave, all of that coming together. Dana, would you like to talk a bit about how the leave is influenced with the AMC's new framework?
Absolutely. Thanks, Michelle. And I'm also speaking partly with my hat on as a member of the board of the Confederation of Postgraduate Medical Education Councils, which recently released a statement on their perspective on access to leave for PGY1 and PGY2 doctors. So not an official accrediting body like the AMC, but an important body in advocating for education and workplace wellbeing for prevocational doctors. So you can head over to the CPMEC website and read that statement if you'd like. The framework does specify, as has been mentioned already, 47 weeks worked, which leaves up to 5 weeks of recreational leave. This is dependent then on your state's enterprise agreement as to how much leave you actually have access to. So places like the Northern Territory, for example, where I work, you have 6 to 7 weeks of leave per year, and you obviously won't be able to take all of the leave that you're entitled to under your enterprise agreement for the first 2 years of work. Somewhere like New South Wales perhaps might only have 4 weeks, and therefore you wouldn't be able to access the full 5 weeks off allowed under the framework, only what's allowed under your enterprise agreement. So taking away this 5 weeks of potential recreational leave that you have, and there's 47 weeks worked, within that 47 weeks, it's stated that your health service may allow up to 10 days of professional development leave to be included in the 47 weeks. And in answer to the question in the Q&A, that includes both PGY1 and PGY2. So if you're looking for some documentation that states that, on the new national framework page on the AMC's website, there's a guide to the prevocational framework for prevocational doctors and a guide for supervisors. And both of those guides on page 9 mention the structure of the term, and they state that it may include up to 10 days of professional development leave as part of the 47 weeks worked. Now, there has been a lot of contention and discussion about the extra sick leave. And there have been reports from trainee doctors coming via various advocacy channels, including the AMA, Council of Doctors in Training, Prevocational Special Interest Group, and also the Australasian Prevocational Medical Officers Committee, about people who have been advised not to take their full 5 weeks of leave, to have some time up their sleeve in case they get sick. And we were obviously quite concerned about this because having people reduce their recreational leave in order to take their sick leave or have to become sick and then subsequently cancel their holidays just leads to presenteeism and is a risk to junior doctor safety and wellbeing, as well as being a risk to patient safety and colleague safety. So after a lot of discussion and advocacy, there was a statement put out by APRA that they confirmed that there are up to 10 days of sick leave that's accepted from the 47 weeks. So you can have 5 weeks of recreational leave and then also have up to 10 days of sick leave within the 47 weeks and still meet the requirements for completion of both PGY1 and PGY2.
Thank you, Dana. And just checking, would anyone else in our panel like to talk about potentially maternity leave or professional development leave as well?
Look, I think Dana's covered the professional development leave. In relation to maternity leave, obviously it depends on the amount of maternity leave that you take. But let's say, just an example, you take 6 months maternity leave within a year, then you will have to take more time to complete the requirements. The medical board's standard in relation to general registration, particularly in relation to the provisional registration interns have, is that you have up to 3 years to complete those 47 weeks, which includes an allowance for you to do it part-time. Essentially, any part-time work will be prorated in terms of how it's assessed.
Thank you. So the next question I want to talk about has been mentioned again via the emails and also into the Q&A a bit earlier. Will be directed towards you, Professor Singer. What happens if the hospital that you're working in is not following the framework? Who you can escalate that to? And similarly, in terms of their terms for the year, is it the responsibility of the hospital or the prevocational doctor to make sure that they're all accredited appropriately?
So it is the responsibility of the hospital that all terms are accredited. That accreditation is done by the Postgraduate Medical Council for that jurisdiction. Though in the case of the Australian Capital Territory, it also covers southeast New South Wales, where there's sort of a joint accreditation process that's done with HETI. So if you have a problem, then all the postgraduate medical councils have a JMO forum, and you should be able to have a contact there where you can escalate a concern around whether a term is meeting the accreditation standards. If you send it directly to the AMC, we will pass it back on to the appropriate PMC. Dana, I don't know if you want to make any comments in relation to CPMEC.
Yeah, I'm happy to. This is something that we'd certainly discuss at APMOC, the Australasian Prevocational Medical Officers Committee, for those who are keeping up with all the acronyms. And we would advocate on behalf of if there was a systemic issue. But as Andrew highlighted, the people that are ultimately responsible for accrediting the hospitals and health services that we work at is the state prevocational councils. So you would advocate to them either directly to the Prevocational Council or to your state's JMO forum in order to advocate back to the council. In terms of making sure that your terms are accredited and are appropriate, in terms of making sure terms are accredited, the PMCs are pretty good at this. They've been doing this for a long time. The tricky thing is going to be the teething problems as the new framework rolls out, making sure the entire year is compliant with the accreditation requirements in terms of meeting the A, B, C, D, as well as the 50%, no more than 50% in one specialty, and no more than 20 or 25% in some specialty, some subspecialty. And there's already been some issues flagged where those haven't necessarily been followed in 2025. And that was also part of that statement that APRA put out late last year that said that they were allowing some leeway in 2025 where some errors had been made in allocations due to just mistakes and teething problems with the framework. But that's likely to become much more strict from 2026 onwards. So I would recommend, just for yourselves, having a look over the term requirements and making sure that you meet them. But if it's the hospital that's allocated you to a set of terms that's not in line with the framework to meet certificate of completion, it's unlikely, certainly this year, that you're going to be penalised and not get the certificate if you have done your best, entered into the program, done all the terms, and through no fault of your own, have not met the AMC requirements for the certificate of completion.
Thank you, both of you, for answering that question. The next one as well has been one that's been touched on with a few different questions in the Q&A and also in the emails as well. Might first direct this to Professor Singer too. So there's a lot of questions related to the consistency with which this framework's being rolled out. Seems to be a lot of variability between different sites and also different states in terms of what's accredited for which category and over requirements for the year. Is this plan to be rectified at all?
So I guess it's actually in part a design feature to allow a level of flexibility in terms of how a term is described and which clinical areas are the focus of that term. It's done essentially as part of the accreditation process by the Postgraduate Medical Council, and noting, of course, that the Postgraduate Medical Councils have their own cycles of accreditation assessment. So, for example, a hospital that you're working at, it might be 2 or 3 years before it actually gets its next full assessment. But essentially, it's the case that those decisions essentially are made as part of the system. So what will be happening in most cases is that your hospital will have essentially made a submission to the PMC with all of the terms that had previously been accredited and how they're being allocated in terms of the clinical domains and etc. And the PMC is expected to have signed off on that. Clearly, there are some challenges, as Dana has already said. There's challenges in terminology. There are also challenges in terms of how hospitals understand what the framework means. So there will be work that will happen to try and bring things into a more consistent state. But it will still be the case that, for example, a general practice term may be given different clinical domains in one setting to what it might be given in another setting, where both are actually appropriate because they both apply to general practice. It is a responsibility of your allocating facility to ensure that you meet all of the clinical experiences that you are required to meet within the course of the year.
Thank you very much. Anyone else want to add on to the answer? So next one.
Sorry, I might just add, if that's okay, Michelle.
Yeah, cool.
Regarding specifically the classifications of the terms, as Andrew said, there will be some differences because of terminology, but also what's considered to be a specialty versus a subspecialty at a quaternary metro centre might be different than what a rural site considers a specialty or a subspecialty, and that's definitely still a teething problem that's going on. But I can post in the chat, every state has already published its list of classifications for all of its terms. So you can look into your state or territory Prevocational Council's website and see a list of all of the terms and what domains they're accredited to, and by comparison, other health services and other states and territories. And there has been discussion between all the PMCs to look at where it's consistent and where it's inconsistent. But there's two other factors, I suppose, to consider about the consistency. The first is that there are different paces of implementation. So ACT and New South Wales, I believe, are fairly advanced in their implementation of things like EPAs, the term discussions, and the term requirements, whereas other states might be still in the process of rolling them out. So the different pace will lead to different rollout approaches. And then secondly, because the internships, as Andrew said, are designed to be different. Equal outcomes doesn't mean exactly the same opportunities. It means that at the end of it, every doctor that graduates with a certificate of completion is qualified to be a doctor in Australia. And what you would learn in Port Lincoln in South Australia would be different to what you would learn at the RA. And that's great. We don't want everyone having exactly the same experiences. So there will be differences, but the outcomes are intended to be the same is the goal of the framework.
Thank you very much. The next question, again, probably directed to Dr. Singer, but everyone else is welcome to join in as well. There's been a couple of questions about international medical graduates and where the AMC framework fits in with international medical graduate pathways and vice versa. Would you be able to talk about this a bit to start with, Professor Singer?
Yeah, so as I previously said, the framework does not apply to international medical graduates who are on a pathway to general registration. But there are a lot of similarities between the clinical domains that are included in prevocational training as well as the clinical domains that are required for an IMG to receive the AMC certificate. And most of you will be aware there are essentially three pathways to general registration for an IMG. There is the competent authority pathway for those doctors who are graduates of a system that is regarded as substantially comparable to the Australian system. So that essentially is the UK, Ireland, Canada, USA, and New Zealand. There is then essentially for those doctors that don't qualify for the competent authority pathway, there is either doing the AMC clinical exam, which now that the new test centre has just reopened, is going to start winding fairly quickly again, or there is also the workplace-based assessment pathway, which a number of different health services offer. All of those providers are also assessed and accredited by the AMC through my committee, and that essentially, whilst doing it in a different way, it essentially is very much a parallel process covering the same issues in terms of assessing the equivalence of an IMG to an Australian graduate. It's based on the same outcomes. I will just note that in the chat there's a question about FGAMS, foreign graduate of an accredited medical school, which is a special category of graduate in the Health Insurance Act. And yes, for all intents and purposes, an FGAM is the same as an IMG. So if you happen to be one of those, you will need to go through the standard pathway in order to get your AMC certificate and then to be eligible for general registration once you've done the 12 months of supervised practice.
Thank you very much, Professor Singer. This next one I'll direct a bit more towards Dana. There's a question in the chat talking about potentially doing 6 months of a real specialty such as obstetrics or pediatrics, and just a bit more touching on the subspecialty versus specialty. I know we've sort of touched on this before, but if you can answer that one too.
Yeah, I think my answer will be mostly the same in that it's up to the PMCs as to how they accredit particular terms, whether it's considered a specialty or a subspecialty. So checking out those websites and getting in touch with your PMCs if there's any uncertainty, or getting in touch with your medical education units would be a good first point of call. They're the ones that report back to the PMCs. It might be the case that ONG or rural would be considered a specialty instead of a subspecialty, and it could be eligible for 50% of the year, but it would depend on the individual health service and how they decided to classify it.
Thank you very much. Now, I noticed there's been a few questions about different hospitals having different timelines with their EPAs. I believe we've kind of covered that as well. We're talking about the differences between the PMCs and the different hospitals. So I will leave that to the side for now, but if someone has another question, feel free to put that in as well. Now, there's been also a couple of questions talking about trying to meet requirements for specialty pathways as well as doing the prevocational framework. Again, we sort of have touched this a little bit with the presentation as well, but did you want to talk on meeting prerequisite requirements to get onto specialty trainings as well as doing the framework as well, Professor Singer?
Sure. So in relation to PGY2 in particular, the additional flexibility is there to allow, so for example, you could do a 6-month term in a particular specialty and then do say 2-3-month terms, one in emergency, one in another related field, or in a particular subspecialty of that specialty. The flexibility again is quite deliberate. So the reason why we've moved away from the old mandatory term descriptions is in order to allow people to essentially be able, obviously in collaboration with their employer, to be able to design something that allows them to fulfil all the requirements that they need. So, for example, it's certainly possible in PGY2 to potentially be able to do a term that's research-based, etc. It's very difficult to get more specific than that because it really does come down to individual circumstances. But I guess to sort of quote a couple of extreme examples. So it would not be possible to do a 6-month term in retinal surgery, as a sub-branch of ophthalmology, and expect that to count. But at the same time, you could potentially do 3 months in that, 3 months in general ophthalmology, and then another 6 months in other related terms, such as do a neurology term or a geriatrics term, which would allow you to meet the requirements. I guess in particular, what we're trying to do here is save people from themselves, to be frank, in that there are a number of people who, essentially have decided, often even before they've gone to medical school, what their career pathway is going to be, and that's great. But it's important to remember that the aim for this is generalist experience. And certainly one of the things that I would stress to any of you who are looking to stream, and I know it's very tempting, particularly if you're a mature age student or intern, but it's important to get that generalist grounding before you go into your specialist training, because once you're a fully qualified specialist, you will always be expected to have some generalist ability in you. So that's the reason why the rules are as they are, and hopefully people appreciate that.
Thank you very much. I know we, again, spoke a little bit about the EPAs, but there are also some questions specifically about who can mark them. I'm going to see if Dana or anyone else on the floor has anything else they'd like to add on this topic.
I'm happy to make a few points initially regarding the EPAs. So there's definitely been a few panicked comments in the Q&A about when they're rolling out exactly. So if anyone's been into the office of a medical education officer, you can appreciate that usually desks are piled high with paper forms from various interns and RMOs with term feedbacks and end of term reports. And for that reason, there was a decision not to implement the EPAs fully in 2025, given that the e-portfolio was not going to be fully up and running by the start of 2025. So there is a flexible approach to implementation. Many health services are starting to implement them at some point throughout the year, and this might be in a paper-based format, or it might be as part of the portfolio, the e-portfolio, when that is implemented. But it will be fully implemented, and the 10 per year requirement will start from 2026 when the e-portfolio is completely up and running. So some health services or states and territories might require 10 this year. Some might not start requiring 10 until next year. So that's the first point. Regarding the sign-off of EPAs, that's a matter of local policy. So some hospitals will be requiring primarily or only consultants, others will allow registrars, and it is generally expected that anyone doing an EPA has done the training modules. There are some great and very simple training modules that have been developed, I believe, by PMCV, and you can find them on their website, and various other organizations that you can even have a look at if you're curious as to what your supervisors are doing. But it is a shift in thinking from the idea of mini CEXs, where it is a pass-fail, to EPAs, where it's about a formative assessment for entrustability to make sure you're getting the feedback that you need to improve. So it's also a tool for us to ask for the teaching that we deserve and that we know hasn't been happening for a long time. So the idea is that anyone doing those EPAs would be doing a training module, and that would include people like clinical nurse specialists or pharmacists who also might be signing them off.
Thank you. Next one I'll mention in the chat as well. So there's probably more of a hypothetical in this sort of situation just because it's early days, but towards you, Professor Singer, what will happen in a situation where there's disagreement regarding local supervisors saying that a doctor has met the requirements for the year? It says, for example, regarding taking a little bit extra more leave, so not having the full 47 weeks, and how those, if there's any disagreements between whether a doctor should meet the requirements for certificate, how those will be managed in the future.
So essentially, this is the responsibility of the assessment review panel. And so in most cases, we expect that to be more than one person, and in a large teaching hospital, we expect it to be a number of different people. So as I said, they're allowed they're allowed the ability to be flexible. In the end, they're the ones that make the decision that gets recommended to the medical board. I guess at least in theory, there is the possibility that if you disagree with the decision, you could take it to the health practitioner ombudsman, but it's going to be pretty rare, remembering that about 95% of interns progress to PGY2, but essentially, if you need to have a discussion, you need to have that initially with your assessment review panel, and then take it from there.
Thank you very much. Either Professor or Dana, next one's about whether in terms of the 2-year framework, what's the starting date? So if someone has started in 2023, their intern year over a couple of years, for example, is the framework relevant to them?
So I think the answer is that the framework is relevant based on what your hospital has done. So, for example, if you given that most jurisdictions are rolling out the framework this year, wherever you are in terms of whether you're in PGY1 or PGY2, the framework applies as of now. It's not that we didn't have a framework before this. It's just there was a different framework with a little bit less detail. So, no, there's no. So, in a sense, there is, I guess, grandfathering, for want of a better way to describe it, of what you've already achieved, and then the framework starts from when your hospital says it's assessing based on it.
Thank you very much. The next one, there's been a couple of questions in the chat and also via email talking about GP training specifically as one of the colleges that accept training starting from PGY2 and the relevance of the certificate of completion in relation to that training. Tina, are you happy to chat a bit more about this?
Yes, absolutely. So obviously not a representative of any college, but I am an ACRM trainee and fairly familiar with the requirements of both ACRM and RACGP as the two primary care training colleges. So you can still apply for the program in PGY1 to commence PGY2, noting that the requirements for RACGP include having done pediatric and ED time, I believe 3 months of each. So it would mean that you would have had to have met those requirements in order to commence training. In terms of whether the colleges will require a certificate of completion, that's still up in the air. Neither college has confirmed. But in terms of the actual process of getting onto training, you can start it in PGY2, and there's no reason that you couldn't concurrently be doing both the college training program and the certificate of completion at the same time. And that's probably what would be assumed and recommended at the moment. The only question that's still up in the air, and that there's still some advocacy and discussion to be done with the individual colleges, and the same with RACP, is the burden of paperwork and term assessments, which is already fairly significant for colleges. Having to do a term assessment form for ACRM or RACGP or any of the other colleges, alongside doing your midterm, start of term and end of term assessments for PGY2, and then perhaps having to do the mini CEXs for ACRM alongside the EPAs of the prevocational framework, would be a significant burden of paperwork and assessment to put on trainees. So there's actually not a definite answer about that at this stage, I believe, unless Andrew's heard any different. And I think that that's definitely something that we as trainees still need to be talking to our colleges and advocating for clarity on in the coming 12 months.
Look, I will just add a little bit. So last week, I was part of a discussion with the committee hosted by the Commonwealth that provides the oversight of rural generalist training. So that includes all of the jurisdictions and the colleges. And there was quite a lot of discussion about how it would work. I would note that currently there certainly are, sort of compulsory hospital experiences that are required by both colleges, and so and in a lot of cases you can't do that in PGY1. You have to do it in PGY2 or above. But it certainly is possible to do more than one general practice rotation throughout the 2 years. You can't do all of PGY2 in general practice, I'm afraid. It would be fairly, one, if you can do that well, you're very lucky. But secondly, I think it would be unlikely you would be able to achieve all the requirements of those colleges for training in doing so.
Thank you to both of you for commenting on the GP pathway. Now, Aidan's also BPT trained as well. So I was just wondering, is there anything you want to add on this topic from a BPT perspective as well?
Yeah, so from the College of Physicians point of view, certainly doctors can start their basic training in their second postgraduate year without the AMC certificate of completion. And that's been confirmed. So the college allows entry into basic training, but providing that you meet all other selection and entry criteria that would be otherwise specified. I think it's worth noting that some PMCs and accredited training settings may have additional eligibility criteria for basic training that applicants will be required to complete PGY2 under the new framework. And I'll post in the chat resources to where you can find, depending on where you're currently working, particularly which state and territory you work in, additional information.
Thank you very much. It's a very topical area. Now, there's a bit more of a general question here, probably directed towards you, Professor Singer. They're wondering about the background regarding why, under the new framework, generalist experience has been emphasised so much. You have to talk a bit more about why that's been the case in the new framework.
So it's always been the aim of prevocational training for it to be a generalist experience. And the reason why that is important is because, as a doctor, you are expected to look after the whole person, and that general experience gives you the skills to be able to do that. So, regardless of how specialised you may end up being, as I said, you are still expected to be able to take the whole person into account, and so that's why this is important. I would also note that our greatest need in terms of medical workforce is in generalist areas. It is not in specialties, and so it's also important in terms of developing the right workforce that the community needs.
Thank you very much for that one as well. Now, sorry, let me just check. I think as well, we were talking a bit about the 2023 intern cohort, but I think Dana wanted to add something onto that as well.
Yeah, I just wanted to get the exact numbers before I mentioned it, but there have been two questions related to completing the PGY1 and PGY2 and what time frame people have to do that in. So this is the requirements for pre-vocational training programs and terms document, which again is on the AMC's website. And it mentions that you have 3 years after graduating to complete PGY1 and 4 years after finishing PGY1 to complete PGY2. So if you have some time that you take away from clinical medicine, go overseas, then you will have more time to complete the framework. And if you don't quite complete the framework in 1 year, so let's say you might have 6 months off during PGY2 for maternity leave, for travel, for chronic illness, for any reason, then you can just come back and complete another 6 months at the same health service to complete your PGY2. So you wouldn't have to start all over again from scratch and do PGY1 from start to finish, although having that job held for you and having space would obviously be a negotiation with the individual health service. Also, with regards to the question on completing the PGY2, if you are coming back from some time away and you've not completed the PGY1 element of the framework, even if you're coming into PGY2 in 2025 and 2026, you're probably still going to be completing the framework because that's how the NEU is operating now. And it is a framework that offers so much more support. So I also wanted to make the point that something that we've been advocating for in various other organizations, AMA, APMOC, have been talking about for years is insufficient support and education for pre-vocational trainees who have completed internship and then suddenly you're out in the world on your own and there's no one looking out for you. So this has been built in response to advocacy from trainees, but also for the benefit of trainees, in that the hospital is now mandated to give you protected teaching time in PGY2. They're mandated to have a program that's tailored for your education with sufficient content to make sure you're learning all the things that you want and need to learn. And you do have to have supervisors who are aware that you exist and who are checking in on you and your well-being as well as your education development. So this is all being done also in the best interests of trainees. And if you're entering PGY2 this year or next year, you will be reaping the benefits of that framework being implemented, regardless of whether or not you've done the first year of the framework.
Thank you for the clarification there as well. One more little one probably before we end up wrapping up for you, Professor Singer. So there's a question about moving between health services, either between PGY1 and PGY2 or in the start of PGY2 in one hospital, then halfway through changing to a different hospital. Is that possible under the new framework?
So it certainly is possible to do PGY1 in one hospital and PGY2 in another. That works fairly easily. In terms of doing PGY2 in more than one hospital, and I'm assuming that we're talking about hospitals that aren't networked together. Clearly, if you're being seconded from another hospital, that works the same as if you're working at that hospital. Look, I think it certainly is possible. It would require a bit of work, though, in that you would need to be able to transfer your PGY2 records from the first hospital to the second one. You would also need agreement from those hospitals to assess you in that way. So certainly theoretically it's possible, but it would require a bit of work on your part. The framework is generally made to be easy if you spend the whole year within a single hospital network.
Thank you very much for that. Now, just in terms of the last couple little questions, so there's a couple in here wanting written information about the PDL leave and the 2-year internship. There are some documents that have been shared in the chat, and afterwards we can also share some more resources as well from AMA. So I'm not ignoring your questions, that's why we haven't specifically mentioned them. And then Dana, potentially this last one for you. If hospital admin's not allocating enough JMO cover for a specific rotation, so this is a bit more broader than just the AMC framework, what's the best point of contact outside the hospital to address this?
Absolutely. So your first point of call beyond your hospital medical education unit would also be your local RMO society, if they're able to do advocacy on that. The RMO societies then also feed back to the state JMO forum, which then has communication and discussion with the state's Prevocational Medical Council, and the names of them all I posted in the chat earlier with links to their websites. So if it is a matter of junior doctor support and safety being at risk, then that's definitely something that PMCs would want to know about, as well as if it's a matter of patient safety being at risk due to understaffing. So if those two are a threat, then certainly that's a pathway you can go to. If there's other concerns also within the hospital, you've got your patient advocate, you've got your medical education unit, and you've got your hospital executive. But outside of the hospital, in addition to that official pathway for accreditation of prevocational terms, there's also always your various advocacy bodies, in particular AMA and ASMOF, who might not be the exact person to help you in that situation, but within your state and territory will know who the key people are that they can refer you on to for extra support and help.
Thank you very much for answering that, Dana. And yes, if you do have any concerns with your hospital and you want to chat to someone outside, you can very much definitely chat to AMA about this. Now, I think that wraps up our chat and Q&A today. Is there any final remarks anyone on the panel would like to make? In that case, thank you very much. Thank you everyone for attending. We hope this creates a platform for ongoing discussion for the ongoing implementation for the framework. From an AMA perspective, we'll be analysing this discussion and the comments and the questions everyone has had, and we look forward to making a set of action items that we can work towards with our colleagues and decision makers to support everyone and all of our prevocational doctors. Thank you again for attending, and we hope everyone has a really good night.
Thanks, Michelle. Thanks, everyone.